Hello, good afternoon and welcome. My name is Susan Morris and I'm a clinical nurse educator at the New Brunswick Heart Center. Today we're going to talk about the evidence and use of targeted temperature management post-cardiac arrest. Allow me to share my screen with you and present a PowerPoint presentation. Okay, so here we go. Targeted temperature management, the who, why, what, temperature, and how of cooling. And this is can be applied generically, but I am going to specifically talk about our practice at the New Brunswick Heart Center. So let's kind of get an idea of the scope of the problem. So according to the American Heart Association, the incidence of out-of-hospital cardiac arrest is around 326,000. So if we translate that to the Canadian population, it's somewhere around 32,000 people in Canada. So the average survival rate is 10.6%, which to many of you newer registered nurses, that might sound like a dreadful survival rate. But in my career, and I've been a nurse for 34 years, in my career, survival rate has doubled. And the reason why it has doubled, it's gone from 5% to 10%. So I can only hope that it will improve. But we can thank bystander CPR for that improvement in survival rate. So the better CPR we give, the quicker we give it, improved outcome. So for those of you who may also be CPR instructors, encourage that bystander CPR, so you can do hands-only CPR if you do not want to touch the person that's down. Hands-only CPR is certainly as effective as our traditional CPR. So survival with good neurological outcomes. So that's really what we all aim for. Nobody wants to survive an arrest and have some neurological impairment. So when you look at neurological function post-CPR, it's only adequate or good in 8.3% of those who have survived the event. So it's not great. Bystander CPR occurs only 44% of the time. That's just sad, and there's no reason for that other than lack of education. So when we look at in-hospital data, it's really difficult to capture the percentage of patients who would suffer a code blue or a cardiac arrest, because people report it differently, people examine it differently. So that data is really difficult to obtain. So let's look at a little bit of the evidence that suggests who should we cool. So the Canadian Cardiovascular Society publishes numerous position statements. This happens to be from 2017. And when we look at what this group of physician group have to say, they suggest out of hospital cardiac arrest. For anybody who has been in a shockable rhythm, there is a strong recommendation that we offer targeted temperature management. Those who come in non-shockable arrest, so PEA or asystole, the evidence is not as robust, but we are offering the recommendation that although the evidence is inconclusive, we evaluated the potential benefit and the apparent lack of risk for targeted temperature management. And so it is a recommendation that we cool all out-of-hospital cardiac arrests, whether they were a shockable or non-shockable rhythm. In hospital arrest, so recommendation number 3 says, we suggest that targeted temperature management be considered in unresponsive survivors of in-hospital cardiac arrest, and they state with any rhythm after return of spontaneous circulation. So they suggest that there is no high quality evidence, so there's no randomized controlled trials to support or disprove the use, and therefore, because of the low incidence of harm, it is recommended that we cool in-hospital cardiac arrest patients. So why do we cool patients? So in the evidence that we looked at in the 80s, there was a high survival rate, but when you looked at 7 or 30-day mortality, it was pretty significant. Patients were not surviving to go home and have a fruitful life. So examining why that happened, it was likely due to the secondary brain injury that occurred after return of spontaneous circulation. So regardless of the cause of the cardiac arrest, all patients will develop some degree of what is known as post-cardiac arrest syndrome. So this is a fairly complex set of physiological processes that happen after a cardiac arrest. And so we'll look at each of the things that happen to the body after cardiac arrest in just a moment. So why do we do it? We do it to mitigate the inflammatory response, the secondary brain injury, assist with the myocardial injury. So cooling is recommended in all of those instances. So when you look at post-cardiac arrest syndrome, there are 4 basic clusters of symptoms that occur in a patient. And so let's examine each of those. So the cardiac arrest brain injury. So post-arrest, we are now reperfusing the brain. And so when we look at the underlying pathophysiology related to that, a secondary brain injury is the cause. So as the clinician at the bedside, you can do nothing about the length of time the patient was down, how long it took to return to spontaneous circulation. As long as we are using our 2015 ACLS guidelines, you're doing the best you can with what you have. So some patients will have a more significant brain injury than others. And the maximum point where brain injury occurs is about 3 to 6 hours post return of spontaneous circulation. So when we think about that, that's when we should be already have our cooling instituted, and we should near be at targeted temperature management, because we aim for 4 hours after induction to reach our target temperature. So you get some cerebral edema that can really cause some significant neurological impairment, and it may manifest itself in comas, seizures. Obviously, we are going to cool the patient who remains comatose after return of spontaneous circulation. So that's one of the inclusion criteria, that you must remain comatose after return of spontaneous circulation. And so when we talk about the secondary brain injury, we look at the potential treatments. Yes, we're going to manage seizures. We're going to have airway protection because this patient will be mechanically ventilated. But the cooling component is what really minimizes the secondary cerebral edema. So brain swelling and cooling are a good combination. So targeted temperature management will assist or minimize that cerebral edema that occurs. Then here is some post-cardiac arrest myocardial dysfunction. So whether this patient has arrested because of a myocardial infarction or not, there is always some accompanying global hypokinesis. What I mean by that is the myocardium is stunned. It doesn't really know what to do very well. So what you're going to see is low cardiac output, hypotension, lots of arrhythmias, both atrial and ventricular. And then your patient could go into complete cardiovascular collapse. And so how do we treat that? So one of the things that we at the New Brunswick Heart Center are advocates of is early revascularization for anybody suffering an acute MI. Early hemodynamic optimization. And so that large phrase just means basically adequate preload, adequate afterload, and adequate contractility. And I'll go into that in just a few moments. IV fluid, ensuring that your patient is adequately volume loaded. This is not the time to be restricting volume. This is when the patient needs the most volume. They may have to have inotropic support, or they may need a device to assist with their cardiogenic shock, like a balloon pump or an Impella. They may even have to go on to an LVAD or ECMO. And those are all available at the New Brunswick Heart Center. But cooling the patient, targeted temperature management, will assist with a number of those things. So if you decrease the metabolic needs, you'll drop the patient's heart rate. There'll be fewer arrhythmias. If you volume load them, there will be less cardiogenic shock. So cooling them, adding adequate volume, you may need to add vasopressors, you may need to add inotropes, or you may need a device to assist with contraction. But looking at all patients will develop some type of global hypokinesis. The degree that happens depends on pre-existing comorbidities and the actual reason for the cardiac arrest. So some assist devices that we use at the New Brunswick Heart Center, picture here on my left is an Impella. So this is percutaneously inserted through a cut down. We often use the Impella 5.0, which displaces 5 liters of cardiac output. But we also have the Impella 2.5 that can be inserted true percutaneously instead of through a cut down. And so basically what happens is this area where I am mousing over, it has a propeller in it, and it basically sucks volume out of the left ventricle and dumps it up here into the aorta. So bypassing this left ventricle, it acts as an assist. Here is our true ECMO machine. So ECMO stands for extracorporeal membrane oxygenation. And basically it bypasses the heart and the lungs. It oxygenates the heart and the body tissues, and it acts as a pump and an oxygenator. So you can have different types of ECMO. You can have venous to arterial. You can have arterial to arterial. It depends on your needs, whether it's for oxygenation or whether it is for pump failure. So this is inserted in either the cath lab or cardiac OR and will act as temporary assists for the patient while they improve their condition. So here are just a couple of websites that you can go in and watch. The Impella, just a little quick video for the Impella and a little quick video for ECMO. And I'll see if I can get these to work. Sometimes it happens and sometimes it doesn't. So let me minimize this. Okay. Not sure if this is picking up or not. Just trying something new today. But the technology is very slow. And so I'm just waiting for the YouTube video to come up. Sometimes it's easier to take these things at home than it is at the hospital, just because of some of the bugs that are in our software, in our firewalls. No, I'm sorry, I can't get it to work. So these are two videos. If you want to share them, you can just type into YouTube Impella or ECMO, and you can find some quick videos for that. So the third thing that happened, so first we had the cerebral edema, second we had the global hypokinesis related to the myocardium being stunned because it hadn't been perfused. And now the third component that happens in our body is sort of this widespread systemic inflammatory response where our body says, wow, what has just happened to me? I was perfusing fine, then no perfusion, and now I'm being reperfused. And so what that does is it activates our systemic inflammatory response. And so we get an increase in coagulation. We get some very strange things happening in our vasoregulatory system. We get some adrenal suppression. We get changes in oxygen delivery and utilization. And there is even a thought that there's impaired resistance to infection. So what will we see in the patient? We may see tissue hypoxia, so higher lactate levels. We may see hypotension, again, that cardiovascular collapse. We may see the patient trying to manifest a fever, and that is difficult in a setting where you're trying to cool the patient. So oftentimes we will give the patients Tylenol to try and suppress that inflammatory response. But to be honest, the one thing that you see that really makes a difference in the inflammatory response is cooling the patient. It almost fools or tricks the body into saying, oh, hey, maybe life isn't so bad. And so cooling the patient also suppresses that big inflammatory response. So as you rewarm the patient, you may get that starting to come back. But once the body has been cooled for 24 hours and you slowly return it to normal thermia, your body has a bit of recovery time. And so the things that we do during targeted temperature management that make special attention to the inflammatory responses, we really closely monitor our glucose. Because of that adrenal suppression, you'll get non-diabetic patients with significant insulin resistance, and as a result, you'll see a higher serum glucose. And so most patients will be on an insulin infusion. But targeted temperature management does a really nice job of quieting that inflammatory response. And so then the fourth component of post-cardiac arrest syndrome is the persistent precipitating cause. What happened to this patient? Why did they arrest? Was it cardiovascular in nature? Was it pulmonary? Was it cerebrovascular? So identifying the underlying pathophysiology and then offering treatment specific to the reason why the patient arrested in the first place. So post-cardiac arrest syndrome is made up of cerebral edema. We also have global hypokinesis of the heart. So you get poor cardiac output. You get activation of the systemic inflammatory response. And then you have the whole thing that ties everything together. Why did this patient arrest in the first place? Is this a fixable issue? Is this something that can be fixed with time, with intervention? And so it's examined as to why this happened to the patient in the first place. So what is the temperature? What are the recommendations? So early on in 2002, when the kind of landmark trials were published that stated we need to cool everybody to 33 degrees. So our parameters were between 32 and 34, so anywhere in there. And then all of a sudden, in I think it was around 2013, study was published in the New England Journal of Medicine by Nielsen and his colleagues that sort of put a significant question mark as to what is the most appropriate temperature. And so based on the trial from 2013, the latest recommendations are you can cool between 33 and 36 degrees. But I'll read you the disclaimer. It says, we acknowledge that the evidence does not conclusively favor a temperature of either 33 or 36. So practitioners may use a temperature range. We favored 33 degrees rather than 32 as a lower could result in a drop further, which can create some significant challenges for the patient and the clinician looking after that patient. So what we have done at the New Brunswick Heart Center is we have determined that the majority of patients will be cooled between 32 and 34 degrees. However, if you encounter any type, excuse me, if you encounter any type of adverse event related to the cooling, then you have the autonomy to allow your patient's temperature to go up as high as 36 degrees. For example, we see a lot of bradycardia, as anybody who cools would see. Symptomatic hypothermia or symptomatic bradycardia is not that common. But people get very nervous when heart rates drop into the 30s. And so a lot of times if our heart rate falls below kind of the threshold of 40, 45, we'll warm the patient up just a little tiny bit until we see the heart rate come up. So that allows us to stick with our current protocol, but have the ability to be flexible when patients develop either coagulopathies or bradycardias, and still stay within the recommendation and know that we are protecting that patient neurologically. So the current recommendation is 32 to 36. Most people will be 33 to 36. Most people will still cool to the cooler temperature, because at the temperature of 36, it's very difficult to control shivering. And so we know that's one of the big adverse events related to targeted temperature management. So patients are less likely to shiver at the lower temperature than they are at 36 degrees. That's just the body's way of saying, I'm going to warm you up when you're 36. At 33, hey, this is way too much work to try and warm this patient. So the patient usually doesn't shiver when they are on maintenance treatment. So this is the clinical trial I spoke of that put head-to-head 33 degrees versus 36 degrees, and their outcome showed no neurological difference between the two groups. There are a large number of physician colleagues across the country that have examined this clinical trial and feel it is inconclusive, that maybe what was hypothesized in the trial was not the same hypotheses that they were looking for in the initial 2002 trial. So there's a lot of controversy. So therein lies a recommendation of that broader range, which gives a clinician more autonomy to determine what they want for each patient. So the thing about the Nielsen trial is 73% of their patients had bystander CPR. Remember on the first slide I told you that 44% was the norm? Where did they come up with these patients who had 73% of them had received bystander CPR? And they're shockable. They were almost all shockable rhythms. So between 79 and 81% for both arms of the trial. So those were some kind of red flags that said, yes, okay, maybe you found that survival in the 36 degrees versus the 33 degrees was pretty even. But when you look at the demographics and characteristics of the patient population, maybe they weren't the same. So anyway, I'm sure that debate will continue on for years to come. So the New Brunswick Heart Center follows this philosophy from Penn State, and they are kind of the cooling gurus of North America. It says it is responsible to not change current practice based on the targeted temperature management trial, but rather continue to treat comatose post-arrest patients with a targeted temperature management goal temperature of 33 degrees. However, the TTM trial provides evidence that a more flexible approach is possible for patients intolerant of 33 degrees, such as marked bradycardia, increased bleeding, or QT prolongation. So clinicians feel uncomfortable treating to 33 degrees. It is acceptable to treat with a higher TTM temperature goal up to 36 degrees. So this is the philosophy that we adhere to. So how long should we be cooling these patients? So we suggest that cooling be for at least 24 hours. And we suggest that target temperature management be continued beyond 24 hours from ROS to prevent fever. So basically what they mean is you can actively cool the patient for at least 24 hours, but then you should be cognizant of not having an elevated temperature. And some groups of researchers go as far as saying while they are in hospital. There's different schools of thoughts on that, so I will leave that to the medical professionals. So at least 24 hours is how long we are cooling them for. So once you have reached targeted temperature management, so whatever goal you set, 33 or 36 or anywhere in between, once you have met that temperature, then you start your timing. So 24 hours, and then we start to rewarm. So please note the following is what is done at the New Brunswick Heart Center. You know, please don't feel that this is the way that it has to be done, but this is the information that I will present to you. So when we look at post-cardiac arrest syndrome patients, their bundle of care, so a bundle of care is just basically a cluster of things that are done to improve mortality. Hemodynamic optimization, I'll talk about that in a moment. Early reperfusion with either lytics or PCI. Always consider targeted temperature management for post-arrest. And do not start prognosticating on their neurological outcome until 72 hours after they have been rewarmed. So they reach normothermia. 72 hours after that is when decisions should be or could be made. So what is early hemodynamic optimization? It's just basically goal-directed therapy that pushes volume. So your patient is or should have an art line and central line in. Hook that central line up to CVP to give you a little bit of guidance. And I know there's all kinds of literature out there to say that CVP is a poor indicator of volume status. However, it is the one that we have available to us. And so it is a guide. You're not looking for exact numbers. You're looking for changes in the trend. So pushing your CVP up a little higher than normal. So normal's 2 to 6, pushing it 8 to 12, meaning you're adequately preloaded or volume loaded. And there are some references that say as high as 15 millimeters of mercury. You're pushing for a MAP of 65 to 90. And if your physician doesn't like to go by MAP, then you can go by systolic blood pressure, and your minimum should be 90. You're looking for mixed venous oxygen saturation of greater than 70%. So that is your most deoxygenated blood. The percentage of oxygen should be above 70%. Aim for a normal hemoglobin. And if you don't have that, then transfusion is indicated. A lactate level of less than 2 millimoles per liter, and a urine output of greater than 0.5 mils per kilo per hour. That's what we mean by hemodynamic optimization, volume loading, and ensuring we have an adequate blood pressure. And that blood pressure can be achieved with norepinephrine and or dopamine, but norepinephrine is the drug of choice, frontline drug of choice. So when we look at the cardiac arrest algorithm, and basically should we institute targeted temperature management, there are a number of things to consider. So we have an out of hospital arrest patient. First of all, we need to decide, are they STEMI or non-STEMI, because they will need PCI or lytics first. And we can safely combine lytics and cooling. We can safely combine PCI and cooling. And so this chart just kind of gives you, if you institute targeted temperature management, some of the decision things that you, parameters you should go through. Over here, are you achieving targets of care? So what is your MAP? What is your ventilation? PO2 and CO2 like? What's your hemoglobin like? So it's just kind of a all-encompassing algorithm to assist the clinician in whether they should be considering targeted temperature management. And if so, what are some of the goals of therapy when we are resuscitating this patient? So some special considerations with cooling. So I find that family often get left out of this equation for the first little while. But during maintenance, once you've got the patient settled, you've got all lines in, you've got them hemodynamically stable, then it's time to concentrate on the family. And they're always going to ask, oh, why is it so cold in here? Why do you have a cold blanket on them? Possibly, why do you have some ice on them? And so basically, our kind of party line, for lack of a better word, is targeted temperature management prevents a secondary brain injury. We can't do anything if they suffered a brain injury because of the cardiac arrest, but we're preventing any further swelling. And most of the time, it's been my experience that patients' families will say, oh, okay, and that really is an adequate explanation for them. The Canadian Council of Cardiovascular Nurses have also put out a document that you're welcome to use. It's on their website, and it's just basically a document you can print off to give to the family that just talks about the who, what, and the why of targeted temperature management. So please, if you don't have access to that, don't be afraid to give me a shout. So Susan.Morris, Morris, at horizonnb.ca, and I can forward that to you. So this is what the brochure looks like. It can be printed double-sided and folded into 3, and it just talks about what does cooling do, why would we be doing this, what should you be doing, and then a couple of credible websites that can take them, so sudden cardiac death, and just a couple of credible websites for the family to visit. PCI and cooling, basically the recommendation is they can be safely done together. Just be sure that the physician who is doing your cardiac cath knows the patient's core temperature, because there may be a difference in the amount of anticoagulation that the patient is given. And that's a physician decision, as long as he or she knows what the temperature of the patient is. So the effects on the body. So cooling minimizes the secondary brain injury, although the initial insult may result in seizure activity. And so sometimes it's quite difficult to determine, is this a seizure or is this aggressive shivering? And sometimes it's really quite difficult to discern between the two. If a patient is not seizuring, there is no evidence to suggest we should be using prophylactic anti-seizure medication. But if they are seizing, then the physicians may opt to add Dilantin. It's important to remember that in the presence of cooling, Dilantin is significantly reduced in its metabolism. So you can see here a 67% decrease in drug clearance. So be aware of that and be assessing for a Dilantin level, because cooling does alter that. So you may need a smaller dose. So just be aware of that. Cardiovascular system, bradycardia is almost always expected, but rarely requires treatment. And again, as I say, bring your temperature up just a bit and your heart rate will come up. We often get a cold diuresis or a big dump of urine when we start to induce therapeutic hypothermia or targeted temperature management. And so you may get a hypotension. So make sure you're keeping up with that volume. The patient can develop something called Osborne waves, and I'll show you those in just a moment. You may also get a prolongation of the PR interval and a prolongation of the QT. Prolongation of the PR is not a huge deal, but prolongation of the QT could set up your patient for what we refer to as R-on-T phenomena, or predispose them to some lethal ventricular arrhythmias. So here is a picture of an Osborne wave. And so when you look in the literature to get a definition of an Osborne wave or a J wave, it's basically, you know how everything slows down when it's cold? Well, so does conduction through the myocardium. And so this Osborne wave develops as evidence that the heart is cold. And it typically occurs when the patient's when the patient's core temperature is below 32 degrees. Once you warm the patient up a small bit, that Osborne wave goes away. When I talk to electrophysiologists about the significance of Osborne waves, they talk about it's just an indicator of slowed conduction through the ventricles. And once you warm up the conduction system, then that conduction gets improved and that Osborn wave disappears. So it doesn't have any prognostic value. So when you see it, it's not like an ominous sign or anything. It's just an indicator that, hey, maybe my patient's too cool right now and I need to warm them up. Respiratory, we actually don't do a whole lot respiratory-wise, meaning initially when targeted temperature management first came about, there was this huge concern that we were going to not be able to measure our blood gases appropriately because our labs do not correct for temperature, and there was a big concern about that, but really that has been put to rest. What we're looking for is a normal CO2 and a normal oxygenation. So our SAT's greater than 94%. We're not looking to hyperoxygenate anybody, but you'll be surprised that your patient actually has lower oxygen requirements because we have lowered the metabolic demand so much. So we may actually have an easier time oxygenating patients when they are cooled than when they start to be rewarmed. The oxyhemoglobin dissociation curve, which is that very complex curve that talks about shift to the left or shift to the right. So what you will see in cooling is the curve shifts to the left. And basically what that means is the hemoglobin has an increased affinity for oxygen. So it's an easier time making a bond with oxygen. And so you might have a bit higher SpO2 than you would without targeted temperature management. And the interesting thing about that is that oxygen binds nice and easy to the hemoglobin, but when it gets to the tissue, it doesn't want to offload. It wants to cling to the hemoglobin and not offload. And so this is where I think the use of a lactate level is a very good measure of tissue hypoxia. So anytime you have that lactate level of greater than 2 millimoles per liter, some piece of tissue is being starved of oxygen. And so you may be able to look at a blood gas and say, oh, wow, I've got a great saturation. My PO2 is 105. Things are great. And then you look at your lactate level and you're like, well, my lactate level's 3. So what that means is there's all kinds of oxygen and it's bound to hemoglobin, but when it gets to the tissue, it doesn't want to give off its oxygen to the tissue. So there can be tissue hypoxia in the state of normal oxygen and normal saturation. So that's why it's important to look at a lactate level. And I noticed that something just came out from our lab that said they will be measuring glucose and lactate with blood gases, so that everybody will be looking at the same parameters now, which is kind of nice. Our renal and musculoskeletal, well, renal, there will be some dysfunction. There's going to be a big cold diuresis initially. The kidneys are kind of shocked and they don't really know what to do. And you get a large dump of urine. Just make sure that you are putting back in what the patient is excreting. So preload can drop very quickly. Vasoconstriction happens because of cooling, so your CVP may be a little bit falsely elevated, and that's why clinicians are saying push for the higher value. That way you know that you have adequate volume on board. As I said earlier, endocrine, everybody is going to, or pretty near everybody is going to require an insulin infusion because of the altered secretion and sensitivity of insulin. And another electrolyte to be aware of is your potassium. As the patient gets cooled, potassium will go into the cell and give you a lower serum potassium. But then as a patient starts to warm up, this potassium is going to come back out of the cell and give you a higher serum potassium. So usually about 3.2 is a threshold of low potassium that they will accept. But we shouldn't be routinely treating all of these patients with potassium, because in the rewarming phase, you're going to get a big influx of potassium back into the serum. GI, I find it interesting that the current guidelines suggest that we should be feeding this patient. I guess maybe I think cardiologists have a good philosophy. Let's see how they do once we rewarm them. So it's very difficult to discontinue feeding on a patient who may not be neurologically intact. It's just one more thing that the family have to think about and consider. And so if it's never started, then it's never a consideration. A lot of times, and most of the time, patients should be on some type of stress prophylaxis with a proton pump inhibitor of some sort. Hematological, it's important to note that your platelets become dysfunctional when the temperature drops below 35. Really quite dysfunctional at 34 and below. So if you find that there are issues with bleeding, etc., that are significant to the patient, then you can increase the temp up to 35 and those platelets should no longer become dysfunctional. So again, a coagulopathy could be an indication to raise the targeted temperature up from 33 degrees, maybe up to 35 or 35.5. Shivering is a big deal to treat because shivering is the body's natural response to try and bring up a temperature. And so if you are trying to cool, shivering is counterintuitive to what you're doing. So every hour, a bedside shivering assessment scale should be used. And the validated tool that we use at the New Brunswick Heart Center is just called the BSAS, Bedside Shivering Assessment Scale. And so each hour, the nurse should take her hand, place it on the patient's mandible. A score of 0 is achieved if no shivering is felt or observed over the chest wall, neck, or mandible. Mild is shivering localized to the neck and thorax. 2 is moderate, where you see gross shivering of the upper extremities, neck, and thorax. And then you get to 3, where the severe, and you can visibly see it all over the trunk, the upper extremities. So oftentimes people will assume there's 0 shivering, but if you put your hand on the mandible and you feel some quivering, then that would be regarded as mild shivering. And we treat shivering with neuromuscular blockade. And when you paralyze somebody or offer them neuromuscular blockade, you also have to offer sedation and or pain medication in conjunction, because you can't just paralyze somebody and allow them to try and fight against the ventilator. Some patients who have been interviewed in the literature have described being paralyzed without sedation or pain medication as similar to being buried alive. So this would be a horrendous experience for anybody to go through. So at the New Brunswick Heart Center, we have started using a BIS monitor, and I'll talk about that in a moment. But some medications that we can use for shivering, we now have this on our formulary for special order patients only, but it's Precedex, very effective sedation medication. If you were using analgesic, fentanyl is a good drug. The only indication left in the world for Demerol is shivering, but we don't have it on our formulary anymore. They talk about application of a bear hugger blanket to keep the patient from shivering. None of these have any evidence behind them. None of the non-pharmacological methods of preventing shivering have been proven effective. So application of bear hugger is not even used in our heart center. Magnesium sulfate is used a fair amount for prevention of shivering. And so you can give 2 to 5 grams over a period of between 2 and 5 hours. And then the neuromuscular blockade. What I do want to bring to your attention is that clearance of these drugs is significantly impaired by cooling. So when you look at vecuronium or rocuronium, 2 of the more common ones used, clearance is decreased by 11.3% for each degree that you drop. So if you drop 3 or 4 degrees, you could alter clearance by close to 45%. So this will result in a prolonged paralysis, a prolonged intubation, and the potential for ventilator-associated pneumonia. So the latest evidence that says Nimbex is the drug that we should be using, and we should be using a train of 4 when we are administering any neuromuscular blocker. And so if this is something new to you, if you are giving and administering neuromuscular blockers, Horizon Health now has a learning package, and it's a certification process for any registered nurse giving neuromuscular blockers. So please ask your educator if that is available to you, and you should be completing that before you are caring for these types of patients. So the use of train of 4 is to limit the amount of neuromuscular blockade that we give. And so there are 4 binding sites on a nerve synapse. And there's no sense giving more neuromuscular blockade if all 4 of those binding sites are full. So what we do is we place a nerve stimulator, usually over the ulnar nerve, and we stimulate it, and it's called a train of 4. It's just a method of stimulation. And so basically we're looking for twitches, our hand to move like this. So if I touched the train of 4 button and I didn't have any neuromuscular blocker on board, this is what you should see. You should see 4 movements. That tells me, the clinician, that 0 amount of the binding sites are full. And so basically what I'm doing is if my patient is shivering, I determine, oh, I think I need to give some neuromuscular blockade. Let me do a train of 4. And if I see 1, 2 or more twitches, then that's an indication that I can give neuromuscular blockers and it would help with the shivering. Again, important, shivering is treated with neuromuscular blockers, but you also have to add sedation and pain medication so that the patient does not experience being awake but paralyzed. Assessing sedation requirements, the recommendation now is to use continuous EEG monitoring. But that is very difficult, A, to obtain, B, to interpret, and C, know what to do after you interpret it. So the best thing that we have decided to use is a BIS monitor, or bispectral indexing. And it's something that is used in operating rooms throughout the country. And it basically gauges the level of consciousness. So, sorry, and let me just go back. So a BIS monitor is electrodes that are placed on the forehead and temple, and they give us a number of between 0 and 100. 100 being awake, alert, coherent, you and I listening here today. 0 would be the patient we're pushing to the morgue. And we are tailoring sedation to get a numeric value between 40 and 60. So we don't want the patient completely conscious, but we want them to be well sedated. And so that numeric value that we have decided is between 40 to 60. So if you see your patient's BIS number, and that's a number that is monitored continuously on a little monitor at the head of the bed, if you see that your patient is starting to become more conscious, then that's an indication to give some sedation. Just be aware that when you administer neuromuscular blockers, that will also lower your BIS. So use it as a trend. If you start to see that the trend is going up, then your patient is becoming more conscious, and there is a fear that they may remember some of this unpleasantness that we offer as a treatment. So please be conscious of that. Neurological prognostication, as I said, the recommendation is 72 hours after rewarming. So induction, maintenance, and rewarming. I'm just going to go through these very quickly because you'll be able to manage this on your site with your on-site educator much better. I will also provide a little, for lack of a better word, a cheat sheet on how to use our Blanketrol. So I'm just going to sneak through this. This is what the little cheat sheet looks like. But I'm going to take you to this nursing worksheet. So this is not part of the patient's health record, but it is a checklist for you as the clinician to use to make sure that you've done all of the things. So initiation of cooling, 0 to 4 hours, targeted temperature 32 to 34. If this were not your temperature, then you would write in aim for 35, whatever your temperature is. And this talks about all of the things that you should be doing as a nurse. The next column is for maintenance. So once you hit that targeted temperature from 0 to 24 hours, the next column is rewarming, so between 24 and 40 hours, and it tells you how to rewarm here using the blanket, and then after 48 hours. So this worksheet here should be used, even though it looks really busy, it should be used over the course of a number of days to help guide you and tell you what to do. It's really nice when the nurse who first cares for this patient fills in the times that the blood work needs to be done. It's kind of nice, it's a courtesy, and just allows you a little more guided care plan for your patient. So if any of you need this, please do not be shy. I will upload it to the Critical Care Network for use for Horizon Health employees. And this is a list of my references. So any of these can be gone through. There is a plethora of literature out there on targeted temperature management. I find it a very interesting topic of research. And so please do not be shy if you're interested or you have questions. just send me an email and I will respond very quickly. So I hope you've enjoyed this presentation, and if you have any questions, just email susan.morris@horizonnb.ca. Thank you for your attention. Have a great day.